Hello and welcome. In continuation of reproductive pharmacology, today we will discuss drugs used to oppose the effects of estrogens and progestins. It is recommended that you may see the lecture on pharmacology of estrogens and progestins on this channel before this one to make a robust and modern foundation and then continue here. So, let's start. The learning objectives are shown. Please take a look. Selective estrogen receptor modulators, or SERMs, produce tissue-selective estrogenic and antiestrogenic effects. Estrogen synthesis inhibitors primarily involve aromatase inhibitors that reduce estrogen production. These drugs are particularly important in hormone-dependent breast cancer. This section of the lecture demonstrates how modern pharmacology increasingly aims for tissue selectivity rather than complete hormonal suppression. SERMs act as weaker estrogen agonists in some tissues and antagonists in others. First-generation SERMs include clomiphene, tamoxifen, and teremifene. Raloxifene represents a second-generation SERM with reduced uterine stimulation. Third-generation SERMs such as basedoxifene and ospemifene are more optimized for tissue selectivity. SERM selectivity depends upon receptor conformational changes and tissue-specific coactivator or corepressor proteins. Different SERMs stabilize estrogen receptors in different structural conformations. This determines whether CO activators such as SRC1 or corepressors such as NCOR and SMRT become recruited. As a result, the same drug may behave as an agonist in one tissue and an antagonist in another. This diagram visually demonstrates how receptor conformation determines transcriptional activity. Estradiol stabilizes the receptor in an active conformation that recruits CO activators and promotes transcription. SERMs may instead recruit corepressors in certain tissues, suppressing transcription. However, in other tissues, the same SERM may still recruit CO activators and behave as a partial agonist. Upon binding estrogen receptor ligands such as estradiol or SERMs, the receptor undergoes a conformational change, allowing the estrogen receptors to exist in a spectrum of conformations from active to inactive depending on the nature of the bound ligand. This conformation, in turn, regulates the recruitment of specific transcriptional coregulatory proteins and the resulting transcriptional apparatus. Coactivators such as SRC1 bind to the active, agonist-bound form of the receptor and activate transcription, while corepressors interact with the antagonist-bound receptor, inhibiting transcription. Depending on the cellular and promoter context, both unique and overlapping sets of genes may be regulated by various ligands. Clomiphene contains two stereoisomers. Zuclomiphene acts as a partial agonist, whereas enclomiphene acts as a stronger antagonist. Clomiphene blocks estrogen-mediated negative feedback on the hypothalamus and pituitary gland. As a result, LH and FSH secretion increase, stimulating ovulation in women and spermatogenesis in men. This is a highly elegant therapeutic strategy because endogenous reproductive pathways are stimulated rather than replaced. GnRH therapy may sometimes be preferred because it avoids certain antiestrogenic effects on the endometrium and cervical mucus. Clomiphene may produce ovarian hyperstimulation, ovarian cyst formation, and multiple pregnancies. Visual disturbances may also occur. Its antiestrogenic effects on cervical mucus and the endometrium may impair implantation and contribute to luteal phase dysfunction. This slide demonstrates an important pharmacological principle. Receptor selectivity often creates therapeutic benefits as well as tissue-specific adverse effects. Tamoxifen is one of the most important SERMs clinically. It acts mainly as an estrogen receptor antagonist in breast tissue and has proven efficacy in estrogen receptor-positive breast cancer. However, tamoxifen behaves differently in other tissues. In bone, it may exhibit estrogenic activity and preserve bone density. Unfortunately, in the uterus it may stimulate endometrial proliferation and increase endometrial cancer risk. Another important point is CYP2D6 metabolism. The active metabolite 4-hydroxytamoxifen is more potent than the parent drug. Adverse effects include hot flashes, vaginal dryness, thromboembolism, and QT prolongation. Basedoxifene is considered highly useful in postmenopausal hormone replacement therapy because of favorable bone-selective effects. It may also be combined with conjugated estrogens as a tissue-selective estrogen complex. Ospemifene is primarily used for postmenopausal vulvovaginal atrophy and dyspareunia. These newer SERMs demonstrate the progressive refinement of endocrine therapeutics toward improved tissue specificity and reduced adverse effects. This table compares how different SERMs behave differently in bone, uterus, and breast tissue. Tamoxifen protects bone but increases uterine cancer risk. Raloxifene protects bone while remaining safer for the uterus. Basedoxifene combines protective uterine and bone effects. Clomiphene primarily acts through hypothalamic estrogen antagonism to induce ovulation. Another way to antagonize estrogen is to block its synthesis. Aromatase inhibitors block conversion of androgens into estrogens. They may be non-selective or selective. Selective inhibitors include steroidal agents such as exemestane and non-steroidal agents such as anastrozole and letrozole. These drugs are especially important in hormone-dependent breast cancer, particularly when SERMs fail. Fulvestrant is a highly effective mechanism for treating hormone receptor-positive advanced breast cancer. Unlike traditional SERMs, fulvestrant is a pure estrogen receptor antagonist and degrader, meaning it not only binds to and blocks estrogen receptors on tumor cells but actively destroys them. Hence it is a SERD, and not a SERM. This dual action shuts down the hormonal signaling pathways driving cancer growth without causing any partial estrogenic stimulation in other tissues. In clinical practice, it is administered as a monthly dual intramuscular injection. Its main adverse effects include injection site pain and symptoms of lack of estrogen. Now we move toward progesterone antagonists including danazol and mifepristone. These drugs are clinically important in reproductive medicine, endometriosis, and medical termination of pregnancy. Their mechanisms differ substantially despite both influencing progesterone-related physiology. Here we compare two drugs, danazol and mifepristone, used to counter the effects of progestin. Danazol is a synthetic weak androgen that suppresses gonadotropin release, while mifepristone is a direct progesterone receptor antagonist. Danazol has historically been used in endometriosis, fibroids, heavy menstrual bleeding, and certain hematological conditions. Mifepristone is highly effective in medical termination of pregnancy and may also be useful in endometriosis and Cushing syndrome. Notice the contrasting adverse effect profiles. Danazol produces androgenic adverse effects and hepatotoxicity, whereas mifepristone may cause delayed menstruation, nausea, and glucocorticoid receptor antagonism. To conclude, estrogen and progesterone pharmacology is deeply integrated with reproductive physiology, endocrine regulation, oncology, contraception, menopause management, and molecular receptor pharmacology. The most important concepts from this lecture include the tissue-specific receptor modulation and suppression of hormone synthesis. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!